Hello, everyone. Welcome back to EKG. We're going to talk a little bit about atrial rhythms today from the standpoint of different interpretations. The atrial set of items, the atrial set of EKGs is our largest set of individual rhythms. So without further ado, let's share screen and move on. All right, here we go. Atrial rhythms. Okay, so with atrial rhythms, we're talking about things that are initiated in the atria. Atrial rhythms that are initiated in the atria include sinus rhythms. However, we're going to pull out sinus rhythms as its own item, which we already covered. And now we're going to talk about all the other atrial rhythms. So don't be confused. Sinus rhythms are not considered a part of atrial rhythms, but I do want you to understand that the sinus node is in the atria. So therefore, when we talk about the atria, sometimes we're including the sinus node and sometimes we're not. And we'll try to be clear on that as we move forward. So what we're going to talk about today are atrial rhythms and atrial activities that are initiated in the atria, but outside the SA node, okay? So again, we're back to our basic rhythms that we talked about before. We have supraventricular rhythms and ventricular rhythms. And on the supraventricular side, the above the ventricles side, we have sinus rhythms, atrial rhythms, and junctional rhythms. And today we're going to focus on atrial rhythms. This will be a good opportunity just to put something in the back of your mind, and that is the one thing that the sinus rhythms, atrial rhythms, and junctional rhythms have in common. In other words, the commonality amongst all supraventricular rhythms is the QRS complex. The QRS complex is always the same. The QRS complex, if you'll recall, is a representation of ventricular depolarization. In other words, ventricle contractile cell depolarization. And because of that, it means that all autorhythmic cells have already fired by the time the ventricles fire. So all autorhythmic cells have fired before the QRS complex happens. So therefore, all supraventricular rhythms will have the same QRS complex, and it is within the atrial activity, the P wave, where we see the differences between sinus rhythms, atrial rhythms, and junctional rhythms. So the first item on our atrial list is a PAC, premature atrial contraction. When we talk about PACs, this is not a rhythm. This is an anomaly within a rhythm. This is, or what I've been referring to up till now as crap. So a premature atrial contraction, a PAC, is something that happens within another rhythm. So for example, we might be having a normal sinus rhythm, and as that normal sinus rhythm is palling along, doing fine, everything's great, and then all of a sudden we have a complex or a cycle that comes in before it's supposed to, and that would be a premature atrial contraction. So it's a single beat or a couple of single beats is what we're talking about now, a PAC. Within an entire rhythm, a PAC will make a rhythm irregular. However, that being said, if you follow the prescribed process that I already gave you, the very first thing you do is to eliminate the crap, which means you will have eliminated the look of that PAC to begin with, and therefore the underlying rhythm is typically regular. The P waves are all sinus in nature, typically, except for the PAC itself, which might be a different shape. And then the P to QRS ratio is 1:1 all the way through. It might be a little bit different with the premature beat. I'll come back to that a little bit later. But the QRS complexes are all normal, including the QRS complex of the PAC. The QRS complex will all look the same, and consequently the T waves should all look the same as well. So a PAC is an impulse or complex that occurs before it's supposed to. So if you're doing your P to P intervals, there'll be a P wave that comes in before it's supposed to. We are talking about atrial rhythms, so we're focusing on P waves right now, not the QRS complexes. Although sometimes we notice that the QRS complex, sometimes our eye notices that the QRS complex came in early, but you're going to work backwards and see that the P wave is the thing that initiated the whole cycle to come in early. Normally, these are clinically insignificant. That means people have PACs every single day. Those of you who have had coffee already this morning probably had a PAC. When you are driving along the road and someone almost hits you, most likely you had PACs. PACs come often throughout the day for most people. So most of the time they're clinically insignificant, meaning they don't really have a clinical importance for us. So the formation of a PAC, something has stimulated an area of the heart. Most commonly, that's going to be the activation of the sympathetic nervous system, but there's an activation of the heart, and one area of the heart got slightly excited or excited slightly faster than any other part of the heart. And so it initiates the atrial depolarization rather than the sinus node. And so we see this P wave that comes in early, and that causes the premature complex to come through, the premature cycle to come through. When I say cycle, by the way, I'm talking about a cardiac cycle. And when I talk about a cardiac cycle, I mean all aspects of the EKG for one cycle, meaning P wave, QRS, and T wave all together. So when I use the word cycle, please put that into meaning the whole compilation of a P wave, QRS, and T wave. The difference in the morphology with PACs completely depend on where that excitable part happened within the atria. So in this little cartoon that you see here, the yellow star is the focus point. If that happens to be the area where the premature beat started, then you can see that the majority of the direction of travel is moving away from our, it's moving to the top and the left of the heart, or for the person, it's the top right heart, which is moving away from our lead 2 lead, which is down by the apex. And so you can see that the P wave would be upside down. So what the P wave looks like in a PAC will completely depend on where in the heart the actual focus started with. However, the QRS complexes, the ST segment, and the T wave should remain normal for whatever is normal for that person. It's just the P wave that'll be different. Often we'll see shorter PR intervals than what is normal for that person. I don't necessarily mean that the PR interval is short, meaning less than 0.12. It'll still be in the 0.12 to 2 range. However, they can have a shorter interval than what is normally there for the person, just because of where the focus is. It's also possible that it's a little bit longer, once again, just depending on where that focus was initiated from. So keep that in mind. And again, whether the P wave is upright or inverted in a particular lead completely depends on what the axis is of that particular P wave, and that completely depends on where the signal was initiated from. Okay. It is possible that you can have a PAC that comes from the sinus node. In other words, it's possible that the sinus node was activated earlier than it was supposed to be, in which case your P wave will look exactly like all the other P waves. It just came in early. And that is a possibility as well, that the sinus node is the thing that gets excited earlier. So if you have a sympathetic response and it has an effect on the entire heart, it's possible that the sinus node still controls everything and the sinus node came in early. Most of our ectopic P waves, they can look like all kinds of stuff, but if you have a normal PR interval, but an inverted P wave in leads 2, 3, and AVF, then you have an atrial premature beat. Okay, a couple of things to understand about P waves. They can be compensatory or non-compensatory, okay? And they can be compensated or non-compensated. So I'm going to talk about non-compensatory and compensatory. Oops, I said that incorrectly. We've got non-compensatory and compensatory, and we have conducted and non-conducted. I think I used compensatory twice. So we can have non-compensatory and compensatory, and we can have non-conducted and conducted. So let's define all those. A non-compensatory pause means that if we take an entire strip, so let's say that we have a 10-second strip and there is a PAC somewhere in the middle of that strip. If we were to do our P to P intervals with our calipers, covering up the PAC, you would note that as you start on the one end, the left hand end of the strip, and did your calipers with your P to P interval all across. So here we have our calipers going P to P all the way through the strip. You would find that, and you've covered up the PAC so you can't see it, or at least you're pretending you can't see it. Your calipers would go from this P to this P, and then your calipers, this distance, should take it to here. Right here is where the next P wave should have come in. But as we see, it was a premature one. But we're going to just pretend that there was a P wave here, and then we're going to go to the next P wave, the P wave that comes after the premature beat. And what we find is that it should have come in here, but it too was a little bit earlier. In other words, the P wave after the PAC did not come back in time with the rhythm that was initiated way over here on the far left. And because of that, we say that it's non-compensatory. In contrast to that, a compensatory pause would be the exact opposite. If I start my calipers here and I go from here to get my measurement, and then I swing my calipers, and indeed it should have happened here, but it did not, but I pretend it's there and continue my calipers on, I note that, oh, this time it did come back in time. The P wave after the premature complex came back in the exact time that it was supposed to have come had the premature complex been normal in the first place. And if that's the case, then we say it's a compensatory pause. The difference between a compensatory pause and a non-compensatory pause, if you think about that for just a minute, it'll tell you that the SA node was not reset in a compensatory pause, and in a non-compensatory pause, the SA node was reset. So a PAC can be a compensatory or a non-compensatory pause. Because PACs come early, because the P wave comes early, it's often that the TP segment, the end of the T wave to the beginning of the P wave, that segment gets shortened. In a lot of cases, it shortens to the point where the P wave actually falls on top of the T wave. So when we're coming through here and we're looking at what the T wave looks like in all of our complexes, sometimes we find that the P wave is tucked up right against the T wave, or in some cases right on top of the T wave. And we get what's called a fusion of those two beats. That fusion of the T wave and the P wave tells us that there is a P wave buried in the T wave. So when you see a premature beat, Often you'll want to look at the T wave that comes before that premature beat and see if it looks different than all the other T waves. If it does, quite commonly it's because there's a P wave that's tucked up inside it. And that'll be an important distinction for us to know that this is indeed a PAC and not some other premature beat. So here's some examples of P waves falling on top of T waves. So here's our T wave, here's our T wave, here's our T wave. Right here, we have our T wave, but there's a little blip right there that's different, that makes it different. And that's a P wave that's tucked inside that. Here, we have this T wave. We'll skip this one because this is the premature beat. We look at this T wave. We look at this T wave. They all look the same, but this T wave looks different. It's much higher than the previous one. And that's because, again, there's a P wave tucked inside it. A good rule for you to follow is if all of the QRS complexes look the same, if all the QRS complexes look the same, then all the T waves have to look the same. Let's put that in a different, let's say that a different way. The QRS complex represents contractile cell depolarization, and the T waves represent contractile cell repolarization. If all the QRS complexes look the same, then it means the path for depolarization was the same in each of those beats. If the path to depolarization was the same, then the path for repolarization would also be the same. So if all of these QRS complexes look the same, then all of the T waves that come after should look the same. So when we have a T wave that looks different than all the rest in a rhythm where all the QRS complexes look the same, that gives you a good suspicion that there is something else happening inside that T wave. And the most common thing to happen inside a T wave is a premature P wave. Sometimes we will have blocked P waves. When we have a blocked P wave, this is where, so a minute ago, I said that we're going to talk about the difference between compensated and non-compensated and conducted and non-conducted. I already talked about the compensation and non-compensation. So now let's talk about conducted or not conducted. When a P wave conducts, what we mean by that is that the P wave caused a QRS complex. So if we have a non-conducted PAC, it means we have a P wave that didn't lead to a QRS complex. In other words, a P wave is present in the EKG, but a QRS is not. If we have a conducted PAC, it means the P wave led to a QRS. If we have, so far we talked about sinus rhythms, and in those sinus rhythms, we talked about sinus blocks, sinus pauses, and arrests, right? However, the sinus blocks and sinus arrests we talked about in those, that we talked about in the sinus rhythm packet, those are rare. They are caused by disease. But P waves are not rare. They're very common. And so if we have a blank area, like you see down here at the right-hand side of this EKG, if we have a blank area, so far, you've learned that it could be a sinus block or a sinus arrest. However, the most common reason why we have a area of asystole, this little area right here, the most common reason that we see that is actually a non-conducted PAC. So a blocked P wave. That means we have a P wave that doesn't lead to a QRS. We have atrial depolarization, but we don't have ventricular depolarization. The most common reason for that is because the P wave came early enough that when it tried to conduct through the AV node was still in its refractory period. And so it didn't respond and it didn't send the signal on because of refractoriness. That's the most common thing that leads to it. So what we see, if you see this area where there should have been a QRS complex, again, look at the T wave before and see if that T wave looks different than the other T waves, especially if all the QRS complexes look the same, like you see in this rhythm strip that you see here. So we see a little blip here that is different than all the other T waves in a rhythm strip where all the QRSs look the same. And because of that, we go up. Yep, there is a buried P wave in that T wave. And then we caliper out all the P waves. And we note that a P wave should have come somewhere right around here. but in this case, it came early. So we have a premature P wave that is blocked. So what we have here is a non-conducted PAC. And again, the most common cause of an unexpected pause is a non-conducted PAC. And again, here's my T wave over here on the left, and then here it is again. And over here, we see the T wave on the far right. The T wave is still the same. This T wave looks different, and that's because there's a P wave tucked in there as well. So the most common cause of an unexpected pause is a PAC. I know that you've been learning and you've been working on your sinus packet, and there's been sinus arrests and sinus pauses in there, but do realize that those are rare. Those are due to disease and pathology, and PACs are common. You have PACs almost every day of your life. And because you have PACs almost every day of your life, some of those come early enough that the AV node is still refractory, and so it doesn't conduct and create a QRS complex in the ventricles. So etiology for PACs, first and foremost, idiopathic or benign. That means we don't really know, it doesn't really matter. Usually sympathetic activity of some sort that's leading to it, but they're benign. They don't mean anything. Anxiety because of the sympathetic system, fatigue because of sympathetic activity that happens when you're fatigued. Certainly drugs like nicotine and caffeine especially can lead to it. There are some disease things that can cause PACs too, so don't think that it's always benign, but almost always it's benign. So most commonly, there is no clinical significance to the PAC. Next, we have ectopic atrial rhythms. So if the FSA node is offline for some reason, then we can get into an ectopic atrial rhythm. An ectopic atrial rhythm is a rhythm that has been initiated because the SA node is not functioning properly. This rhythm needs to be under 100 to be an ectopic atrial rhythm. Otherwise, we'd be into a tachycardia. So if it's under 100, it's an ectopic atrial rhythm. And most EARs, most atrial rhythms will be in the 60 to 80 beats per minute range, barring any sympathetic activity. P waves will be non-sinus. It's hard sometimes to tell if they are within a normal PR interval, but inverted in our leads 2, 3, and AVF, then it's absolutely ectopic atrial rhythm. If they're upright, but within that normal PR interval, we really can't tell if it's sinus or atrial unless we have a previous EKG of that patient and that we can compare it to. So just kind of keep that in mind. If they're upright in leads 2, 3, and AVF with a normal PR interval, then we wouldn't necessarily be able to say it's ectopic atrial rhythm. We would just probably call it sinus, unless we had the ability to see a previous EKG of theirs that shows their P waves. So in this case, it's a rhythm where the ectopic atrial pacemaker functions someplace other than the SA node. It's under 100 and usually 60 to 80 beats per minute. The PR intervals are usually normal. It's possible they could be slightly prolonged depending on where it's coming from. The QRS complexes, the ST segment, and the T waves are all normal. These are most commonly stable, regular rhythms, and they can happen in all kinds of different people for all kinds of different reasons. And most of the time, they're transient. So most of the time, they go away and the SA node comes back. There are some times when they don't, but most of the time they do. And so here are some examples. A couple of hints for you. One, if you have the ability to compare an old EKG strip, then do so. It tells us a whole lot when we can compare strips with patients. And then the second thing is it's the P wave and the PR intervals that you are using as your basis to determine whether or not an atrial rhythm is in place versus a sinus rhythm. Generally speaking, a PR interval that is equal to or greater than 0.12 is something that will be originating from the atria. That includes something that's originating from the sinus node. Remember that the sinus node is in the atria. If it's greater than 0.12, it's coming from the atria someplace. Even if it's greater than 0.2, it's coming from the atria someplace. If, however, the PR interval is less than 0.12, then we say that it's being originated in the AV node, not in the atria at all. So just by convention, we're going to talk about the PR interval in that manner. If it's less than 0.12, we say it's coming from the AV node, and I'll cover those in another session here. So our ectopic atrial rhythm, it can be also idiopathic or benign. Every once in a while, we'll have something that kind of gets a hold of the heart for one reason or another, and it leads to having this rhythm for a while, and it might not mean anything. But there are some things that are pathologic that can lead to it, such as certain problems with the anatomy of the heart or some structural heart disease that is causing an area of the heart to be more excitable than the SA node, or the SA node is failing. Those are possible. Then we have atrial tachycardia. You'll see atrial tachycardia listed a variety of different ways. Sometimes it's called ectopic atrial tachycardia. Sometimes it's just called atrial tach, and sometimes it's called paroxysmal atrial tachycardia. The word paroxysmal has gone by the wayside a little bit, but we still see it once in a while. The word paroxysmal literally means you saw it start or you saw it stop. So you wouldn't call something a PAT, a paroxysmal atrial tachycardia, unless you actually saw it begin or saw it stop, or you had a patient that basically said, yeah, everything was normal, and then all of a sudden my heart has started racing. Something that tells you that it was an immediate start or an immediate stop would let you say that it's paroxysmal. Other than that, you can't really say it is. So if you don't know how it started or stopped, so an atrial tachycardia is one that has a rate of about 100 to 180 beats per minute. And everything else is the same as an ectopic atrial rhythm. It just is faster than 100. The rates, again, are usually between the 100 to 180 beats per minute, but just be aware that it can go as much as 250 beats per minute in some cases. The P waves are present, but they are ectopic, meaning you have that inverted P wave and leads to through AVF, but a PR interval that is still greater than 0.12. The P to QRS complexes are still the same. The PR intervals, again, are normal or even prolonged. The rhythm tends to be regular. And again, the QRS complexes, the ST segment, the T waves tend to be normal within themselves, but do be aware that this is an ectopic rhythm, and the tachycardia in an ectopic rhythm can start to put some stress on the heart. So you might have some ST and T wave abnormalities compared to a normal strip of that same patient. And here are some examples that you see here, or an example you see here. This P wave is inverted, but with a normal PR interval, but it's the same all the way through. And we have a tachycardia, 300, 150. It's about 100 and I don't know, 120 or so. So we have an ectopic atrial tachycardia. So oftentimes be aware that a PAC can be initiated by, an ectopic atrial tachycardia is often initiated by a PAC. So, for example, if all of a sudden you were surprised by something and are fearful of it and your heart starts to pump fast, oftentimes that initial surprise, that initial reaction that jumpstarts that is a PAC from the sympathetic activation. And that PAC sometimes can get into a rhythm. And that rhythm tends to be an atrial tachycardia. That rhythm will go back to sinus as soon as that sympathetic activity calms down and that area of the heart is less excitable and the SA node starts to get control over everything else again. So that's often atrial tachycardia is initiated by a PAC. Again, it could be idiopathic or initiated by some sort of sympathetic response. There are some drugs that can do it. Again, caffeine, nicotine, and alcohol are the most common. Stress and anxiety certainly are there. And then there's obviously a host of disease problems that can lead to it as well. That's not the more common. Again, most commonly it's related to sympathetics. However, we are dealing with becoming paramedics. And as we become paramedics, we're dealing with people that are calling 911 and they don't usually call 911 because of a sympathetic response. So we often can see atrial tachycardias in our patients that have pathology as well. Wandering atrial pacemaker is a condition in which there are multiple places within the heart, within the atria, that are initiating the pacemaking response and sending that signal to the AV node. It's possible that this is an irregular rhythm, and it's also possible that it can be somewhat regular or irregularly regular. Often wandering atrial pacemaker will get into kind of a pattern that you'll see, so it can actually fall fairly regularly or have an irregular regularity. But it's also possible that you get an irregular rhythm to it as well. It's just common that you find a pattern to it. So we'll start by saying it's an irregular rhythm, and just in the back of your mind know that oftentimes you can find a pattern to it. And it's caused by having different pacemakers in the heart besides the SA node. And because that, you're going to see different P wave morphologies, and also because there's different places that the P wave is being initiated from. The path to the AV node takes different time frames, which means your PR interval will also be slightly different with each of the different morphologies of the P wave. Though within a strip, all the P waves that do look the same will have the same PR interval with themselves. So just keep that in mind. So there's kind of two forms of wandering atrial pacemaker. There's our classic definition of it, and then there's what we refer to as the clinical variation. Kind of the classic definition of it is that we see a transition that happens with the P wave, where the P wave slowly transitions as the focus of the pacemaking starts to follow a pattern in the heart and goes from one place to the next, to the next, to the next, to the next, until it repeats. That's what we refer to as our classic wandering atrial pacemaker. On a clinical side, what we just need to see are 3 different morphologies of a P wave, which tells us there's at least 3 different sites. And actually, sometimes we'll get quite specifically, 3 or 4 different parts of the heart that all have their own pacemaking going on. And then it just kind of depends on when they get control over the heart. So with a classic wandering atrial pacemaker, you'll see that the P waves just look a little bit different as they move along. And so like what you see in this particular strip over here on the far left, we see almost no P wave at all. And then the P wave looks like it's getting larger and larger and larger and larger. And then eventually it starts to get smaller and smaller and smaller again. So it went into a pattern. And we can clearly identify 3 different places where we've got 3 different looks of a P wave. So in our classic wandering atrial pacemaker, we can still it still meets the clinical definition as well. The clinical variation is literally we have at least 3 different parts of the heart that are trying to control the pacing of the heart. And so what we see is that each of the different pacemaker sites are all firing on their own, and based on refractoriness of the AV node at various times, sometimes they get through and sometimes they don't. And the final strip that we see is one that shows all 3 of the different pacemakers that are firing, but in an irregular pattern. The most common cause of wandering atrial pacemaker is lung disease. Lung disease is the most common reason why we start to see a wandering atrial pacemaker. Respiratory failure can be there. Atrial enlargement is also a possibility. And in kids, it actually is a normal variant as the heart is developing. And before we really get into a system where the SA node has that pacemaking form completely developed, we sometimes see wandering atrial pacemaker as they're leading towards that development. Next is multifocal atrial tachycardia. Multifocal atrial tachycardia meets all the same criteria of wandering atrial pacemaker, except it's a tachycardia. So we have a rate between about 100 and 150. So it's a little bit of a slower tachycardia compared to ectopic atrial tachycardia, but it can still move right along. And the definition is the same as what we saw for wandering atrial pacemaker, in that we need to see at least 3 different variants of the P wave to note that it is multifocal atrial tachycardia. So we have a supraventricular tachycardia caused by at least 3 different atrial pacemakers. Again, it can be as high as 250, but most commonly it's between the 100 and 150 range. So a slightly slower tachycardia compared to the atrial tachycardia. It's often an irregular rhythm because of those 3 different pacemaking sites. But again, sometimes it can fall into a pattern that you'll find. And then just be aware that sometimes you have buried P waves because of the differences in all the places that it falls. An aberrancy is common, which means commonly with multifocal atrial tachycardia, you'll also find that you have some level of blockage in places. And so you'll start to see either widening QRSs or other things that show you that that aberrancy is present. From a clinical history, this is very commonly seen in lung disease and in older individuals as their pacemaking cells start to fail. So treat whatever the underlying cause is. Again, the etiology can be the same as wandering atrial pacemaker, except for we add in here theophylline as a drug. Theophylline is an asthma medication that used to be really common, and it's a medication that can cause the multifocal atrial tachycardia fairly easily. Just a couple more rhythms. Atrial flutter. In atrial flutter, we kind of get into a pattern where the atria kind of becomes cyclical. There's not necessarily a singular pacemaking site. It just starts firing over and over and over again in kind of a cyclical pattern. I think this will be one of the things that I'll want to pull aside probably next term or later in one of the labs this term to kind of draw this out for you. But with atrial flutter, the atria get into a cyclical pattern where basically they never stop. It's just cell-to-cell conduction in a cycle that from the time the first cell fires into a cycle to the time that the signal comes back to that same cell, it's ready to fire again. And so it just fires over and over and over again. And so what you see, what represented down here in letter B of this particular strip, is that you see the atria firing over and over and over again with no baseline. There's no time in which the signal stops and has a portion of baseline. So in other words, you don't see segments. You just see the firing over and over and over again. This is where we start to have to recognize that the atria and the ventricles are 2 separate hearts. So the atria starts to fire commonly right around 300 beats per minute. And then the ventricles will typically start firing at some multiple or some division of that atrial rate, which I'll talk about in just a minute. The atrial waves are no longer referred to as P waves. They're referred to as capital F waves, and they kind of take on a sawtooth pattern to them. And by that, I literally mean a sawtooth, where you just constantly see these spiked waves that never have a flat area. They never have a baseline area. So the atrial rates are in that 200 to 400 range, right around 300 beats per minute. And the ventricular rates will be some lesser multiple of it. So sometimes it's exactly half that rate, or a third that rate, or a fourth that rate of the atria. But most of the time it's a regular rhythm. We have capital F waves, not P waves. And there's no associated isoelectric segments, meaning there's no area where we see baseline between the different F waves. And again, it gives you that, what we call the sawtooth pattern. The F waves, again, are made because of this reentrant mechanism that happens where they start to fire in the cyclical pattern that allows the atria to basically just to continue to fire over and over and over again in a pattern. And it eventually causes the atria to just never have a moment of rest. This is a moment to kind of discuss terminology for a second. Conduction versus block. When we want to talk about ratios, and here we're talking about the ratios of P waves to QRS complexes. If we refer to a conduction ratio, we are saying if we have a conduction ratio of 3 to 2, we are saying for three P waves, for any 3 P waves, 2 of them have QRS complexes with them. In other words, a conduction ratio means how many QRS complexes were conducted compared to how many P waves did we have. So a 3 to 2 conduction means we had 3 P waves and 2 QRSs. If we use the word block, we're saying out of however many P waves we have, how many of them are blocked, meaning how many QRS complexes were taken away. So a 3 to 2 block means that for every 3 P waves, 2 of them are missing QRS complexes. So a 3 to 2 block would be the equivalent of a 3 to 1 conduction. I hope that made sense there. Sometimes we will use the word block and sometimes we'll use the word conduction. When we talk about a flutter, we typically talk about it in relation to conduction. When we talk about AV blocks or heart blocks, we talk about it in relation to blocks. So it's important to understand what that terminology means if we're talking about a conduction ratio or a block ratio. The most common atrial rate in a flutter is 300 beats per minute, and the most common conduction ratio is a 2 to 1, meaning for every 2 P waves, there's 1 QRS, which means every other P wave is blocked. If we have an atrial rate of 300 with a 2 to 1 conduction, then it means the ventricular response should be exactly 150. So we will look at our A flutter and we will count the number of capital F waves that we have per QRS complex. So here, this middle one you see is what we call a 4 to 1 conduction. I know that you think you can just see 3 F waves, but remember there's no baseline, and that means there's an F wave buried inside this QRS complex as well. So inside the QRS complex is 1, here's 2, here's 3, here's 4, and then it starts over again. So for every 4 F waves, we have a QRS complex. For every 4 F waves, we have a QRS complex. So we have a 4 to 1 conduction. For every 4 F waves, we have 1 QRS conducted. So a 4 to 1 conduction. That would be the same as a 4 to 3 block, but again, we use a flutter in relation to conduction rather than block. But we do have a 4 to 3 block here, right? So here's 1, 2, 3, 4 F waves, and 3 of them, 1, 2, 3, were blocked. So there's that. And the bottom one here, a 2 to 1 conduction. Most of the time, our ventricular, our QRS complexes are narrow, but it is possible that you start to see some widening of those complexes, especially if we have an aberrancy. of some sort, so some reason why things are going cell to cell. We could have a bundle branch block, or we could have some electrolyte anomalies that start to widen out that QRS complex. But for the most part, in an A flutter, and an atrial flutter will have narrow QRS complexes. It is possible that we get a variable conduction with our atrial flutter, and what that means is that we cannot count a conduction because they're all different. Like here we have 1, 2, 3, and then a QRS complex. Here we this would be number 4 in this system. Here we have 3 and then 1. Here we have 1, 2, 3, 4, 5, 6 and then 1. Here we're back to 3 of them and then 1. So it's all over the place. If it's all over the place like that, where we can't distinctly have an exact number of F waves to an exact number of QRS complexes, then we say that it is atrial flutter with variable conduction. And that's caused by, again, constant fluctuations in the conduction ratios through the AV node. And most commonly, that's because the AV node itself has some level of pathology. There's something wrong in the AV node that causes it to not be conducting in a normal or in a regular pattern of some sort. So, and it can make our A flutter be irregularly irregular. The etiology is most commonly bad stuff. So MIs can do it. Arterial disease can do it. Digoxin is a common drug that can do it. Rheumatic heart disease, alcoholic holiday heart. These are all things that are part of pathologies that we're going to be studying later in class. So any number of different things can lead to it. This MAD rat PPP is a common way to think of A flutter, and our next one, Afib. I'm not going to ask you to memorize MAD rat PPP, but just realize that usually A flutter and Afib, the next one that we're going to go over, are caused by pathologic means rather than benign things. And so without further ado, atrial fibrillation. Atrial fibrillation is one of our most common arrhythmias that we see in patients. So Afib, it is the most common irregular rhythm to the point where, and I'm going to say this and I want you to listen carefully, if you have an irregular rhythm, the first rhythm you should think of is atrial fib. There are some other rhythms it could be. It could be a flutter. It could be wandering. It could be multifocal atrial tachycardia or wandering atrial pacemaker. It could be a sinus arrhythmia. There are some other irregular rhythms. However, Afib is by far the most common one that is irregular. So if you have an irregular rhythm, Afib should be the rhythm that you are ruling out before you start thinking of any other rhythm. Here we do not have P waves. We have little F waves, so lowercase F waves. And what we're seeing with what we mean by lowercase f there is fibrillation waves, waves that don't have an exact pattern to them. We have atrial activity going on, but it's not forming an organized atrial depolarization. So we don't see a P wave that is forming in any significance. And consequently, the atria portion of the heart is quivering. It is not delivering blood flow in a uniform pattern like it's supposed to. So it's an irregular rhythm that does not have P waves. It has little F waves. And there's no way to tell what rate the F waves are traveling at because they're coming from all over the place. So it's an irregular rhythm with an absence of any observable P waves. The fibrillation is because there are many different parts of the atria that are trying to fire, but none of them are actually able to create a unified depolarization of the atria. And the ventricular response is going to vary based on whatever the AV node can extrapolate out of whatever's happening in the atria. So you'll want to discern the difference between, say, little F waves, the fibrillation waves, and say, artifact of some sort, right? Because artifact and the fibrillation waves can look similar. However, artifact will not change the regularity of the rhythm. And in Afib, you'll see a completely irregular pattern to the QRS complexes. There are some different classifications of Afib. You can have paroxysmal Afib, which is an Afib that comes in little episodes. There's some frequent recurrences of it, but it goes away. So paroxysmal Afib goes away automatically on its own in those patients. Persistent Afib is a chronic form of Afib, but when we provide a calcium channel blocker or cardioversion, we can bump the Afib away and go back to a normal sinus rhythm. And then there's permanent Afib. Permanent Afib is another chronic form of Afib, but it can't be converted, or if you do convert it, it will spontaneously revert back to Afib again very quickly. And that's a more serious form of Afib, and often will have to be dealt with a cardiologist. How Afib is formed is where you have multiple areas of the atria that are all starting to initiate their own impulse, but all of them, none of them can actually get control over the atria in any unified way, and therefore we don't see atrial depolarization as a unified muscle, and because of that, we don't have blood flow from the atria to the ventricles. Blood passing to the ventricles is just done through its passive filling of the ventricles. We can have a whole spectrum of presentations for Afib, from fine Afib to coarse Afib and everything in between. So you'll look at the size, the amplitude of the F waves to determine this, to determine if it's fine or coarse Afib. And that lets you know the level of electrical activity that's happening within the atria at the time of this particular Afib presentation. There is something called Ashman's phenomenon. Ashman's phenomenon is an aberrancy that sometimes develops when you have Afib and you have a longer pause between one R wave and the next, followed immediately by a short pause. In other words, as the Afib's pumping along, sometimes you have a longer pause before the AV node is captured and sends the signal. And then there's a shorter pause where the AV node tried to fire again. However, sometimes it fires too soon and the right bundle branch is still refractory. And because the right bundle branch is still refractory, but the left bundle branch is ready to fire, the firing goes to the left side, but then has to go cell to cell through the right side, and it widens out that QRS complex. So in the middle of Afib, if you see a wide complex QRS complex, and then you look and you note that it came right after a long R to R interval, then most commonly that's Ashman's phenomenon, and not to be confused with a premature ventricular contraction, which we haven't talked about those yet, but we will in a couple of sessions. But a wide complex QRS, a wide QRS complex that happens in the middle of Afib that comes after a long R to R interval is most commonly what we call Ashman's phenomenon, which happens because the right bundle branch was still in its refractory period. And it doesn't mean that there's a right bundle branch block, and it's not actually a PVC either. And then just a note here, digoxin is a medication that you're going to learn about, and it's a medication that that causes many different arrhythmias or arrhythmia effects. Digoxin is one of those drugs that has a very long half-life and a very small therapeutic window, which means it can become toxic very quickly. With digoxin, sometimes you'll see this ladle look or this ice cream scoop look that can sometimes make the ST segment look like it is depressed when in fact it's being caused because of digoxin. And so often we see kind of this down sloping ST segment that comes to a little point and sometimes a little dip right here and then rises very quickly. And that's the digoxin effect. So if you look at the strip you see here in lead 2, this kind of down sloping ST segment with a little dip and a quick rise. Let me go back, a little dip and a quick rise. You see it here in lead 2. You see it pretty prominently over here in V6, V5, and V4 as well. Here's another one. Again, you see it right here in lead 2. And again, over here in V4, 5, and 6, this down sloping ST segment with a little dip and a quick rise to the T wave is that digoxin effect that we see. Afib can be caused by the same things that we see with Flutter, so that mad rap PPP. But it can also happen because you've got an enlarged atria, especially on the left side. It can happen just because it is age-related. And every once in a while, we'll have somebody that gets into Afib and we don't know why. That's idiopathic. I will say that Flutter and Afib can, because they are often caused by many of the same things, you can actually see them together. So you can actually have Flutter, or you can have Afib, or you actually can have a rhythm that shows a little bit of both, in which case we say we've got Afib Flutter, Afib/Flutter, and that's possible too. Our treatments for Afib and Aflutter are the same. We treat them with either calcium channel blockers or we treat them with cardioversion if we need to treat the rhythm itself. So there's that. They both are responsive in the same way. Sometimes Afib is a little bit more responsive to calcium channel blockers and Aflutter is a little bit more responsive to electricity, but our treatments are actually the same for both of them. So again, some of the same causes for Afib and Aflutter. There's a lot of people that have Afib and we kind of think, okay, how bad is it for people to have Afib? Well, realize that 80% of our blood flow passively flows from the vena cavas straight through the atria and right into the ventricles. In other words, 80% of ventricular filling happens passively and has nothing to do with atrial contraction. So atrial contraction only tends to contract about 20% of our ventricular fill. In other words, atrial contraction only affects about 20% of our cardiac output. So we say, well, how important is it for us to know that people have chronic Afib? Well, nobody in this picture is going to have chronic Afib. Or if they are, they're not going to be able to do this. So it'll have to be corrected. So people here are not going to be in Afib because losing 20% of our cardiac output off the top because the atria aren't able to contract is pretty significant when we're doing activities like this. However, all of these people could potentially be in Afib, right? They're not doing heavy activities. They don't, that extra 20% of the cardiac output, is going to make it difficult for them to climb a bunch of stairs and run some races, but it's not going to be hard for them to sit, play some chess or play some cards or sit around talking, that kind of thing. So just kind of realize what people with Afib can and can't do. And the problems that are associated with Afib, the absolute number one thing is that as blood's pooling in the atria, that allows blood to be stagnant. And if blood is going to be stagnant, then it'll allow platelets to aggregate. And if platelets are going to aggregate, then we can have blood clots that form. And if blood clots form, then we can have some problems. The biggest issue is that our blood is supposed to go from the right heart through the lungs to the left heart, which means blood is supposed to filter through the lungs. In other words, if we have a blood clot in our body, it's supposed to get filtered out in the lungs. However, because the left atria is stagnant, blood in the left atria can start to form clots that can break loose and drop into the left ventricle. And from there, the left ventricle sends it directly into the aorta. Based on how blood flow flows through the aorta, blood is directed pretty quickly into the carotid arteries, which means it's quite possible that a blood clot in the left atria gets broken off into the left ventricle, pumped up into the aorta and right into a carotid artery and straight up into the brain. And so our big concern with AFib is the increased possibility of stroke. So people that are in AFib, chronic AFib, will commonly also be on a blood thinner of some sort to manage the risk of stroke. If we have AFib that has a rapid ventricular return, we call that AFib with RVR, rapid ventricular return. That's an AFib that's traveling at about 140 beats per minute or faster on average. So it's an uncontrolled rate. Our concern with that is that we already have a reduction of our cardiac output by about 20%. And now we start making the heart burn pretty fast. And because of that, it can become ischemic pretty quickly. So AFib with RVR is a concern because of the significantly reduced cardiac output and the high possibility of cardiac problems because we're overworking the heart, but not giving it the cardiac output and food supply that it really needs. So this top rhythm, that is better than that bottom rhythm. The top one they're both AFib, but the top AFib is a slower AFib and the bottom AFib is a pretty fast AFib. And because that bottom one being so fast has the higher potential to allow that reduction in cardiac output to cause some significant problems. So because of all the chaotic electrical activity that's in the atria right now during AFib, the big problem is that it reduces that cardiac output, as I already mentioned. And if the atria don't contract, we already know, how does blood flow get into the ventricles? Well, most of it is passive. 80% of our blood flow travels into the ventricles passively, just because the ventricles are lower than the atria. And so blood flow that drops into the atria flows straight to the ventricles. And that's how we have plenty of cardiac output to live, but not enough cardiac output to actually do significant activities. All right, let's stop that. Okay, that's a lot. There's atrial rhythms. I'm sure that there's going to be some questions that come up with that. So I will drop in and answer some questions either during one of these sessions or a session with Chris. Or next week, I think that most likely either next week or the week after, one of these EKG sessions will not be a video, but will actually be in person via Zoom, so that we can answer questions and do some of these in real time. So go ahead and take a look at the atrial section of the red book that you got, and see if you can start to analyze a few of those. You should be through or continuing to get through the sinus rhythms. So the next time that we can meet in person, we will actually look at all the sinus rhythms and atrial rhythms and see if we're on the right track with them. All right, good luck, and I will speak to you soon. Always feel free to throw me an email if you have any questions. And again, I will drop in on one of the classes so that we can have some time to do some of these in person.